Hi, my name is Anthony D'Amico, and I'm a radiation oncologist, and I work in Boston at the Brigham and Women's Hospital and Dana-Farber Cancer Institute. Today we're going to discuss the evidence surrounding the duration of hormonal therapy in the management of localized and locally advanced prostate cancer in patients undergoing a primary radiotherapeutic approach. I don't have any disclosures associated with this presentation. When we look at the randomized trials that describe the appropriate treatment for men with low and intermediate risk prostate cancer in the setting of radiation with or without short course hormonal therapy, there's one study by the RTOG started in 1994-9408 in which back then low doses of radiation, 66.6 Gray, were given with or without a short course of hormonal therapy. That study was reported in the New England Journal of Medicine now 2 years ago, and after a median follow-up exceeding just 9 years, they saw an improvement in overall survival by 5% at 10 years, and that was significant. When they did further subgroup analyses, they found that this improvement was really driven by men with intermediate risk and specifically Gleason 7 prostate cancer. They found no survival benefit in men with low-risk disease, and there's the hazard ratio, including 1 within the 95% confidence interval, so this was not significant. And this has important implications given the concerns raised about hormonal therapy, particularly in men with cardiovascular morbidity, as to whether any hormonal therapy should be used in low risk. There's no survival benefit, there's potential for harm, and so reducing a prostate size, for example, for brachytherapy would really not be a good idea in men with low-risk disease who have cardiovascular issues. However, in men with intermediate risk disease, it prolongs survival. 2 other studies, one from Australia, the TROG 9601, and one from Boston, the Dana-Farber trial 95096, looked at men with intermediate and high-risk disease. The doses in those studies, again, were conservative given the era in which they were performed, being 66 and 70 Gray, and the randomization was to either no further hormonal therapy or 6 months. Again, in both of these studies, there was a significant improvement in overall survival. In fact, both studies showed a 13% improvement by 10 years after median follow-ups that approached a decade. While you cannot compare the two side by side, it appears that the survival benefit with 6 months in absolute value was more at 10 years, 13%, than in the RTOG study, 5%, when using only 4 months of hormonal therapy. To try to get an understanding about the duration of short-course hormonal therapy in men with intermediate-risk prostate cancer, the RTOG ran another study, 9910, in which they looked at 4 versus 9 months of hormonal therapy, and again, a conservative dose of radiation at 70.2 Gray. Most of the men in this study were intermediate risk, 84%, 16% high risk, and after a median follow-up of a little over 9 years, this study was just published this year, 2015, in the Journal of Clinical Oncology, and they found no difference in their primary endpoint being death from prostate cancer. The 8-year point estimate for cancer survival, prostate cancer-specific survival specifically, was 96 versus 95% in the 9 versus 4-month arm. Now, some issues have arisen as a result of this study for the following reason. If one takes a look at the recent classification of intermediate risk into unfavorable and favorable, where unfavorable is anybody with 4+3, or at least 2 intermediate risk factors, being a PSA between 10 and 20, or clinical stage T2B or T2C disease, or someone who has a Gleason score of 7. If you have at least 2 of these factors, then you're considered unfavorable. If you have a 4+3, you're unfavorable, or if the percent of positive biopsies exceeds 50%, that is more than 6 biopsies positive on the 12-core sample, that's unfavorable. Everyone else, 3+4s, less than 50% biopsies, no more than 1 factor associated with intermediate risk, are favorable. So here's some data from the Dana-Farber study stratifying men's long-term cancer-specific mortality by these 3 risk categorizations: high, unfavorable, intermediate, and favorable. After a median follow-up almost of 15 years, what's striking is that in the favorable intermediate risk group, not 1 patient died of prostate cancer. That number, as you can see there, for cancer death is 0%. Now, given that, and given additional data here from the Prostate Cancer Brachytherapy Institute in Chicago, where you see men getting brachytherapy with favorable, intermediate, and low risk had no significant difference in cancer-specific death, and the numbers are less than 1% death in both arms, getting out to 14 years. And when you also look at favorable, intermediate risk stratified, whether they got a short course of hormonal therapy or not, again, no significant difference in the cancer-specific mortality rates when you go out over a decade. This argues strongly that men with favorable, intermediate risk disease do as well as low-risk patients and do not need hormonal therapy. So, if we take that into account, then one might think about that RTOG study, if we go back to it and look, in which they randomized men 4 versus 9 months. We don't know of that 84% intermediate what proportion were favorable versus unfavorable. If a large proportion of that 84% was favorable, then no duration of hormonal therapy would be necessary to decrease the death rate from prostate cancer, and this would dilute out the ability to see a difference in the 4 versus 9 month question if a difference really exists. And so it's really, this study is inconclusive as to whether or not more than 4 months of hormonal therapy are necessary for men with unfavorable intermediate risk prostate cancer to further reduce their death rate from prostate cancer. So as it stands now, 4 months and 6 months, based on the randomized studies, are both options. Now, if we look ahead at unfavorable intermediate risk, some data again from the Chicago Prostate Brachytherapy Institute. This is a retrospective look. It's adjusted for known prognostic factors, but it's striking because what it says is that for men with unfavorable intermediate risk, taking external beam and doing a brachytherapy boost, the line in blue, leads to higher cancer death rates than simply doing a short course of hormonal therapy. On average, it was 4 months, and then brachytherapy, the red line. You can see that there's a significant reduction in cancer death for men who got the short course hormones and brachy as opposed to those who got external beam and brachy. This is particularly important because there's no randomized trial addressing this question, and the toxicity of brachytherapy and beam is higher than brachytherapy and hormones when it comes to rectal and urethral issues. So this creates the possibility that we should be doing short course hormonal therapy at least in men with unfavorable intermediate risk, no hormonal therapy in men with favorable intermediate risk at a minimum in order to minimize death from prostate cancer. This is some work from my colleague Neil Martin, which I find quite interesting. He was asking the question, given all the excitement about multiparametric MRI, in whom with unfavorable intermediate risk would a multiparametric MRI be able to disclose high-grade prostate cancer, Gleason 8, 9, or 10, that was not suggested by the biopsy, Gleason 7. And so what he did was he took a radical prostatectomy series performed at the Brigham and Women's Hospital and found that of the men who had Gleason 4 plus 3 unfavorable intermediate risk, 14% of them had Gleason 8 or 9 at radical prostatectomy, so 15% upgrading, which is not unexpected. But when he asked the question, where were these men? If you look at the black bar, which rises above all the rest, these are men who had a low PSA, under 5, and the core length involved with prostate cancer exceeded 70%, or met or exceeded 70%. And so what you're really saying here is it was people with large tumors but low PSAs. And that kind of makes sense when you think about a large tumor diameter on a biopsy sample, and a low PSA suggests that this large cancer is not making much PSA or is dedifferentiated, and thereby being the higher grades, Gleason 8 or 9, as seen in this study. So if you're asking who should we get a multiparametric MRI in, who's going to undergo radiation to determine whether we should be giving a short or a long course of hormones based on the Gleason score, because with Gleason 7 or less you'd give a short course, with Gleason 8 to 10 you'd give a longer course, it'd be men who have low PSAs, under 5, but their tumor core lengths suggest a large cancer, a core length 70% or more. So in summary of what I've said so far, we realize that when trying to think about the optimal duration of hormonal therapy in intermediate risk prostate cancer in men undergoing radiation, we have to realize that favorable intermediate risk, based on the data I showed you, may not need any hormonal therapy at all. They behave like low-risk patients. And this is not surprising given that in 2005, the International Society of Urologic Pathology met and essentially started calling what we used to call Gleason 6, now 3+4, which is favorable intermediate risk. It may very well be what we call favorable intermediate risk today was low risk before 2005, and that's why the prognosis is not that different. And we never gave hormonal therapy to low-risk patients as part of therapy, so why would we give it to favorable intermediate? So the 99-10 study of 4 versus 9 months may not be able to measure a difference if a lot of men had favorable intermediate risk disease, because no hormonal therapy may be necessary to decrease cancer death, and so asking a 4 versus 9 month question won't work, and it doesn't answer the question for unfavorable. Unfavorable intermediate risk may very well need more than 4 months of hormonal therapy, and there are 2 randomized trials, one through the RTOG looking at high-dose radiation with or without 6 months of hormonal therapy, and it includes men with unfavorable intermediate risk. That should be able to answer the question in the setting of high-dose radiation, do we need 6 months or not? And then there's a study out of Spain, the DART 0105 study, which showed that for men getting 28 versus 4 months of hormonal therapy and high-dose radiation, that high-risk patients benefited. Intermediate risk, there were not enough events yet to determine whether longer courses than 4 months were necessary. The trials are in place to determine whether more than 4 months of hormonal therapy will be needed for unfavorable intermediate risk prostate cancer patients. A little more time will tell. But for today, 4 or 6 months remain an option. And we talked a little bit about where to get a multiparametric MRI to identify occult Gleason 8, 9, or 10 prostate cancer in men with Gleason 4+3 unfavorable intermediate risk disease. And these are men with PSAs under 5, but who have a large percentage core involvement, 70% or more, as measured by the core biopsy. This slide is important because it gets at the current information regarding whether dose-escalated radiation is helpful in terms of reducing metastases and cancer death. There are 3 studies, one from the MD Anderson, one from the American College of Radiology, and one more recently from the RTOG, which was the largest, having almost 1,500 men. Essentially, the randomizations were an additional 10 gray or 1 week of radiation. And if you look over at the column that says progression-free survival, PFS, all the studies show improved progression-free survival with the higher dose. 2 studies showed a near significant distant metastatic decrease, the MD Anderson, and the RTOG showed a significant decrease in distant mets from 8 to 5% at 10 years. But no study has shown a survival benefit or a decrease in prostate cancer death. When you look at the toxicities, you see that all of the studies show increased GI toxicity, that is rectal bleeding, and 2 of the 3 studies show increased GU toxicity, that's mostly prostatic urethral stricture and bladder neck contracture. These are late toxicities, seen usually at least 3 to 5 years after the completion of treatment. So the question remains, who should we dose escalate? We can't show a survival benefit. There's a slight reduction in METs and increased toxicity, and this means that patient selection becomes very important. You don't want to take somebody with a high AUA symptom score or a large prostate with a median lobe and give them higher doses when they're elderly and have comorbidity, because they'll never live long enough, likely, to see the benefit in distant METs, and they'll get the toxicities which occur a lot sooner than the distant metastatic-free survival benefit. So who might be an ideal candidate for dose escalation? That's somebody who is healthy, almost irrespective of age, has minimal BPH-related symptoms, and someone who's not on Coumadin or aspirin or any other anticoagulant that could predispose them to the risk of rectal bleeding. Those people might very well live long enough to get the distant metastatic disease-free survival benefit, which could translate into a decreased cancer death rate and without undue toxicity. So in summary, for low and intermediate risk prostate cancer, what we see is that for men with low risk and favorable intermediate risk, there are several treatment options. High-dose radiation in the appropriate patients, as just discussed. Brachytherapy, if they are an optimal candidate, or radical prostatectomy. There's no role for hormonal therapy in these men. And if these men are in not good health, have comorbidities that could shorten their life expectancy, like insulin-dependent diabetes and a history of an MI, then active surveillance might be their best option. Unfavorable intermediate risk prostate cancer, the level 1 evidence would suggest that conventional doses of radiation with 4 to 6 months of hormonal therapy are our standard level 1 evidence-based options. Post-randomization analyses of RTOG-0815 and the Spanish study 0105 will determine whether 6 or more than 4 months of hormonal therapy adds to dose-escalated radiation. It appears that high-dose radiation alone in the form of external beam and a brachytherapy boost or just external beam may be insufficient for long-term eradication of the disease from the study I showed you from Chicago. It appears that for unfavorable intermediate risk, at least a short course of hormonal therapy is indicated. Moving on now to locally advanced prostate cancer, there are 3 randomized trials that are important. The first one at the bottom of the slide came out first in the New England Journal in 1997 by Michel Bola and his colleagues through the EORTC, which said that adding 3 years of hormonal therapy to standard dose radiation, including treatment of pelvic lymph nodes, decreased the risk of death in half, hazard ratio of 0.51 at a median follow-up of 5.5 years. Then the 2 studies above, both the intergroup and the Swedish study, showed that, in fact, you need both treatments in order to get the best outcome. People questioned the Bola study saying, do we need the radiation? Would 3 years of hormonal therapy be sufficient? And so the top 2 studies asked the question in the setting of baseline hormonal therapy for at least 2 to 3 years, what does radiation add? And in both studies, you see that radiation reduced the risk of death. In the first study, hazard ratio 0.68, a 32% reduction at a median follow-up of 7.6 years. And in the second study, a 30% reduction with a hazard ratio of 0.70 at a median follow-up of 8 years. So we know that for locally advanced, high-risk prostate cancer, the need for both radiation and long-term hormonal therapy is established. The questions that remain is, do we treat pelvic nodes, how much radiation, and how long should the hormonal therapy go for? We'll address those next. We know that 36 months now is a standard of care in terms of duration of hormonal therapy for men with high-risk prostate cancer treated with conventional dose radiation. So if one wants to establish that a shorter duration of hormonal therapy has efficacy that is not inferior to a 36-month course, requires a non-inferiority trial. This is a trial that requires upfront a clinical decision on what the upper limit of the increased risk of death one would accept to say that the lower duration of hormonal therapy is not inferior. Why would one want to even give less treatment when we know there's a survival benefit? It's because, as we all know, hormonal therapy has a litany of unfavorable side effects that start with simple things like hot flashes, gynecomastia, anemia, decreased sex drive, but to more complicated things like decreased mineral bone density and perhaps renal dysfunction, cognitive dysfunction, but most concerningly, cardiovascular events that could be fatal or non-fatal. So limiting the amount of hormonal therapy perhaps could limit the toxicity and then would justify a non-inferiority trial. One such study was done by the EORTC, 36 versus 6 months. They set the upper bound on the 95% confidence interval for the hazard ratio for all-cause mortality at 1.35, which means at most a 35% increased risk of death with 95% confidence would occur in men receiving 6 months as compared to 36 months, and they said we'll accept this as not inferior given the toxicity of hormonal therapy. That study enrolled nearly 1,000 men. The median point estimate was 1.42 increased risk of death, 42% increased risk of death for 6 versus 36 months, and the upper bound on the 95% confidence interval was 1.79, too high, much more than 135, so they rejected non-inferiority. What came along next was a 36 versus 18-month hormonal therapy study in men with high-risk disease from Canada. This was designed as a superiority and not a non-inferiority study. So they didn't enroll as many men as you would need to answer the question in a timely fashion, only 630. Their point estimate was 1.15, which was closer to 1, but the upper limit on the 95% confidence interval was 1.59, again, more than 1.35, and that was at a time when 147 deaths had been observed. What they are doing is they're currently extending the follow-up of the study to include more deaths, because they need 275, given their current study sample size, to assess non-inferiority with an upper limit of 1.35. We look forward to the results of this study because many of us would like to give less than 36 months of hormonal therapy to men with high-risk disease because of the toxicities I mentioned. So here's a summary of the 3 studies we've talked about, the 36 versus 0, 6, and 18, showing the median follow-up, the number of men, and in the third column, the hazard ratio for the risk of death with the shorter duration of hormonal therapy. And as you can see, as you go from 0 to 6 to 18 months in the investigational arm, the point estimates approaching 167, 142, down to 115. And the absolute survival differences at the median follow-ups in the most right-hand column is approaching 0 as you go from 18.3 to 3.8 to 0.4%. And so it appears that 36 months may very well be too much and 6 too little for high-risk disease when giving 70 Gray radiation. But 18 months may be just right, and we just need a little more follow-up to see if that 1.59 value drops below 135 when they reach the appropriate number of cancer deaths to make that assessment using a post hoc non-inferiority trial design. This slide is important because it gets at the issue of what's happened over time as a result of PSA screening and helps us to interpret the final set of slides in this talk. These are 2 randomized trials, one from Spain, the DART 0105 in the top row, and one from the RTOG 9202. These studies had exactly the same randomization, 28 versus 4 months of hormonal therapy, except that the difference is that the radiation dose in the Spanish study was 78 Gray on average, and only 70 Gray in the RTOG, which was done 15 years earlier. If you look at the eligibility for the Spanish study was T1 beta 3, PSA under 100, and had equally distributed intermediate and high-risk patients. In fact, their median PSA was 11, whereas in the early PSA era RTOG study, they had locally advanced men with T2C to 4, PSA under 150 with a median of 20, and all high risk. And so the RTOG study was much more advanced. And even though if you look at the Gleason 8 to 10 proportion in these 2 studies, they're both the same at about a quarter, 25% or so, we would believe that the cancers in RTOG 9202 were larger, just based on the median PSA and the fact that they were all high risk, and more likely to be Gleason 9 or 10, so more advanced. Now let's look at the number of deaths that occurred in these studies. The RTOG, which was a much larger study, 1514 versus 355, had 227 deaths when its median follow-up was about the same as the DART study, a little over 5 years. There were 87 deaths due to prostate cancer, where in the DART study there were only 5. Yet, when you look at the overall survival comparison between the 2 arms, the second column from the right, you will see that there was a significant improvement in overall survival at the median follow-up, 8.7%. in the Spanish study, but not in the RTOG study. And this may very well be because the cancers in the RTOG study were larger, more advanced, and probably higher grade. If you look at the intermediate subgroup of the DART study, it's not a significant difference in survival with longer, 28 versus 4 months. P-value is only 0.32, but there's only 5 cancer deaths. They were all in high risk, so we need more time with the DART study to see if a greater duration than 4 months of hormonal therapy prolongs survival in men with intermediate risk disease. The toxicities are also quite interesting. If you look, the DART study found no significant difference in grade 3 or higher GU and GI-related toxicities, but the RTOG found a 3% increase in GI-related toxicity, mostly rectal bleeding. Now this could be, if you look again in the DART study, there's a 2 versus 1% difference in GI late grade 3 toxicity, which wasn't significant, but the sample size, again, is much smaller and the event rate is smaller, not as large as the RTOG. So this suggests to me that there probably is an increased grade 3 toxicity as a result of longer-term hormonal therapy based on the RTOG study and what the DART study is kind of suggesting. And one might hypothesize, how can this be? We know that testosterone is an important factor in healing wounds. And so it may very well be with longer-term hormonal therapy, the ability to heal the inflammation that radiation causes to the anterior rectal wall, particularly in the serosa where the blood vessels live, may be lessened to a small degree in some, and there may be a small increase, therefore, in rectal bleeding requiring coagulation or steroid enemas to correct. Here's a summary of all the randomized controlled trials that have looked at different durations of hormonal therapy in men who had high-risk disease. What I want to call your attention to is the third column, percent Gleason 8 to 10. I've rank ordered them from least to most. And I went through the fact that the two studies I just presented, the 28 versus 4-month study, had about a quarter of men with Gleason 8 to 10, but I put a star next to the DART study because, as I was saying earlier, they're less likely to have Gleason 9 or 10 or grade 5 prostate cancer because they were done much later in the PSA era. The median PSA was less, and therefore the Gleason scores, although not reported to the level of 8 versus 9, 10, are probably less. Now, where were the survival benefits seen in these studies? Only in 2. And it happens to be those 2 that had the lowest percent high-grade cancer. The 36 versus 6-month EORTC with only 19% 8 to 10. Most of the high-risk cancers in that study were based on clinical T3 disease, based on digital rectal exam. And the 28 versus 4-month DART 0105 or Spanish study, a quarter of them had Gleason 8 to 10. I suspect very few with 9 or 10, given that it was done later in the PSA era as compared to the RTOG study. So we have a hypothesis that can be generated from this slide, which is that as you have increasing amount of high-grade disease, particularly Gleason 9 or 10, or grade 5, which composes 9 and 10, that you become less sensitive to standard hormonal therapy. Some people have postulated that Gleason 9 and 10 cancers have an neuroendocrine component which doesn't respond to standard hormonal therapy, and maybe the grade 4s that you see in Gleason 8s do. So that's a hypothesis. Is there any way to assess if there's any truth in this? Because if there was, then we might start thinking about alternative forms of hormonal therapy in men with Gleason 9 and 10 prostate cancer, such as enzalutamide and abiraterone, which has been shown to prolong survival in men with castrate-resistant and metastatic disease. So I turn your attention now to 2 randomized trials done, one at the Dana-Farber and one in the Australians. I showed these earlier. These were radiation plus or minus 6 months of hormonal therapy. They included intermediate and high-risk patients. And what I show here are the cancer-specific mortality curves, cumulative incidence for men undergoing radiation with or without 6 months of hormonal therapy on the left in the Harvard Dana-Farber study and on the right in the Australian study. And you see that there are significant reductions in cancer death in both of these studies for men with purely Gleason 8 or less disease, no grade 5. When we compare the distribution of prostate cancer prognostic factors among men with Gleason grade 5 in those 2 randomized trials, something emerges quite interestingly. First of all, you see in the Australian study, the PSA was twice as high on average, significantly so. There was many more people with T3-4 in the Australian study, much fewer with T1C as compared to the Harvard study. And there was an approach to statistical significance with a p-value of 0.06 for men having more Gleason 9 and 10 in the Australian versus Harvard study. If you look in the Harvard study, there's only 4% 10 versus 8% 10 in the Australian study, 82 versus 92% 9 in the Harvard versus Australian study, and nobody in the Australian study that we know had Gleason 7 with tertiary grade 5, which would be counted either as an 8 or a 9, but with grade 5. So what we can say from this is that the Australian patients harbored more grade 5 cancer than the Harvard patients. And so the question is then, let's look at the cancer-specific mortality plots just for the men who had Gleason grade 5 disease and see if the increasing proportion of grade 5 in the Australian cohort predicted for less benefit. And here they are, and it's exactly what it shows. On the left is the Dana-Farber study where grade 5 was present. There's still a benefit, but not significant, p-value 0.27, to adding the hormonal therapy with regard to cancer death in these men. It wasn't significant probably because there's only 22 men in this subcohort. If you go over to the right-hand panel, the TROG study, where there was much more Gleason grade 5, again not significant, but the difference in the curves is much less. The reduction in the point estimate of cancer death from the hazard ratio is much less. It's 0.51, which means a 49% reduction versus 0.10 in the Harvard study, or a 90% reduction in death. Again, not significant because of the small numbers, only 38 patients in this group. But what we can see here is that as you increase the amount of grade 5, the ability of 6 months of standard hormonal therapy, an LHRH agonist and an anti-androgen decreased. So, for high-risk prostate cancer, the duration of hormonal therapy currently that's accepted as standard based on level 1 evidence is 28 to 36 months, and maybe when the Canadian study reaches sufficient power to assess in a post hoc manner a non-inferiority design, we'll adopt 18 months. It appears that the benefit of long-term conventional hormonal therapy decreases as the burden of grade 5 prostate cancer at biopsy increases. And while this is level 2 evidence, it suggests that future study may be needed to improve survival in men with Gleason 9 and 10 prostate cancer, where the vast majority of deaths are, and this may include novel forms of hormonal therapy, such as enzalutamide, which I mentioned earlier has been shown to prolong survival in men with metastatic and castrate-resistant disease, and docetaxel, which has also been shown now in 2 studies, the CHARTED study, and just in a press release last week, or this week, on May 13th, the STAMPEDE study, which will be presented at ASCO in 2 weeks, also shows a benefit to adding docetaxel to men with metastatic disease. So these 2 drugs may be worth investigation down the road in men with grade 5 Gleason 9 or 10 prostate cancer at diagnosis to see if we can further decrease cancer death rates with these manipulations. I'll finish here with just one case. Based on level 1 evidence, what would be the management of someone who's 72, healthy, has seminal vesicle invasion clinically, T3B, Gleason 4+4 on biopsy, so no grade 5, high volume, 11 of 12 course positive, and a PSA of 25? Would we do brachytherapy, just high-dose radiation? Is this somebody would give radiation and short-course hormonal therapy? Would we survey this patient? Or would we give radiation and hormonal therapy for at least 18 months? And the correct answer is choice 5, based on the discussion we just had. I hope that this was helpful, and thank you for your attention.